Thanks, Ashley. Thanks for all your help. Again, thanks for all of our sponsors, and thank all of you for attending with us tonight to talk about these articles. We have several guests tonight. We have one of the authors, Matt. We'll get to him in just a few minutes when we get, I think, Matt, we'll probably talk about the first article first and save yours for a second, if that's okay. But we'll get to those in just a second. We have, as always, my good buddy, Phil Page, who didn't miss me a couple of weeks ago, apparently, at the ICAS meeting. That really hurts. That really hurts. Craig missed me. I don't know why you couldn't, Phil. Yeah. I know you did. I just don't know why Phil doesn't.
No, because you never gave me barbecue. That's why.
I've got barbecue anytime you want to come to Wichita, man. Anytime. Anytime.
Everybody, Phil Page here from Baton Rouge, Fran Yu. Thanks for being here. Thanks to our guests. Thanks to our sponsors. Look forward to a good discussion.
Great. And our special guest, we have our main special guest tonight is one of our good friends, Craig Garrison. Craig, tell everybody just briefly, quickly about yourself, and then we'll introduce the general.
Sounds good. Yeah. Thanks, Rob. Thanks, Phil, for having me. Thanks, Ashley. I appreciate it. Name is Craig Garrison. I am Director of Research and Education at Memorial Hermann Rocket Sports Medicine Institute in Houston, Texas. Lane Bailey and I work together. Russ Payne, all of us down in Houston with Walt Lowe, John Conway, and a bunch of other surgeons. So excited to be on and talk about some of these articles tonight to discuss mats for sure. And then really excited also about the pitching mechanics. So to kind of dive into that a little bit.
Great. Thanks, Craig. General, where you at? There you are. There's the general. General, introduce yourself really quick for everybody.
Hi, George Davies. I'm a professor of physical therapy at Georgia Southern University in Savannah, Georgia. And thanks to IJSPT, to Ashley for all the work that she does, and for Rob and Phil for inviting us. I look forward to participating. Thank you.
Thank you, George. So, guys, our first talk. I think the author's Takuya Aso, he was not able to join us tonight. So we're just going to be discussing it by ourselves, but let's start out with it. It's the title of the article is The Effect of Repetitive Pitching on Trunk Muscle Endurance and Thoracic and Shoulder Kinematics. Okay. This is like, I think this is a really interesting and really good article. I mean, this is something that, to be honest with you, I don't know that I look at thoracic kinematics. I look at shoulder kinematics. I look at a lot of shoulder range of motion, strength, endurance, and things like that with my pitchers. But to be honest, I don't know that I look at trunk muscle endurance and or thoracic really mobility probably as much as I should. So Craig, I think one of the first questions I have for you is not even really related to this article as much, but how do you assess trunk rotation in your pitchers? I mean, do you do it just generally, or is there like a real deep analysis that you do when you look at it? And how do you do it, and what do you look for?
Yeah, Rob, great question. So first, the first answer is yes, we do look at it. We think it's very important. Unfortunately, we haven't figured out a way in the last 15 years that we're really good at it, right? And so we think when we look at thoracic mobility, we kind of classify it in, we think that you have to have some mobility and stability, right? So with all of our pitchers, especially that come in, the majority of these individuals are in a kyphotic posture, right? And so, which means to us right away that maybe they don't have that thoracic extension that we need. And you'll see a loss of a little bit of rotation as well. So we do a quick screen with it where we use a dowel rod and look at it in a seated position. And then we also can look at it. We've got another way where we look at it in a prone position, just kind of really isolating the pelvis and looking to see what kind of, do they have thoracic extension and thoracic mobility to the throwing side and to the non-throwing side, right? So what does that look like? The other piece of it, though, I think that maybe we get a little better sense of is just in a prone position to see, do they have that posterior to anterior mobility, right? So that those PA moves, do they even have thoracic mobility to begin with? Because for us, we'll start thinking in our mind, let's say we've got a pitcher that's got a right-handed pitcher, and he's got a shoulder injury, even a UCL or some type of injury in the elbow. What we're looking at is can that scapula actually get positioned on that thoracic cage in a right position. So can we actually get into posterior tipping and retraction, or if we're going into that throwing motion, can we get anteriorly tipped and protracted? And most of the time we see that thoracic mobility is an issue, right? And so, but I don't know that we have not, in the last, like I said, 10, 15 years, come up with a good way of really assessing it.
That's what I was thinking too. When you look at, you said you look with the dowel rod, you have them like, the dowel rod over their arms and then they do the rotation thing.
Yeah. We're here. Yep. If it depends. Okay. If they can't get in that position, then we're here. Yeah.
And then do you just measure it through like the transverse plane?
Yep. You got it.
Okay. And do pitchers normally have more rotation to their dominant side because they're rotating that way when they're throwing?
Ideally, you would like to see that, yes. And so that's, again, I think we all know this on the call, but we like to think of everything in a symmetrical manner, right? And that's not the case with pitchers.
Not in pitchers.
And so
totally,
we have to take
throw
that
out the board. Yeah. Good stuff. Craig. Thanks. Phil, do you have anything? Or, I mean, I have a bunch of more questions I can ask, but I don't want to hog the session if you've got some things. You want me to move on?
No, the part with the thoracic part of the chain, I mean, you're connecting the lower body to the upper body. So it's a huge issue. And people just think about the pelvis and the hips. And what we look at is a lot of this thoracic rotation that's measured by that shoulder, that hip shoulder angle. And so, or the relationship between the hips and the shoulders, we want that separation. So the theory is that the greater the amount of separation between the hip and the shoulder, and the more that it occurs earlier at the hip relative to the throwing motion, theoretically, that would give that kind of spring-like mechanism where you're pulling the trunk to then whip into that upper extremity. And in terms of their, what they found, they only found a couple of 3 or 4 degree differences, and so y'all are talking about mobility, but they were really focusing on the endurance.
Right.
Yeah.
Endurance isn't the question here, because the throw, as we know, is more of that anaerobic, really fast, thing that's occurring. They didn't see a decrease in velocity, but they didn't see a true, probably relevant decrease in range of motion, but they did have, some changes in endurance. But the thing that interested me with this study is they focus too much, again, on these p-values, which most of these studies do. And people need to realize that it really wasn't clinically relevant, in my opinion, to have a 3 or 4 degree change with no change of velocity.
Yeah. So statistically, but not necessarily clinically.
Yeah. Sorry, Rob. Phil, I think that's a great point, is that we get so caught up in the statistical significance, which may not mean anything. We find things statistically significant, but it may not mean anything clinically. And I think that's a great point that you bring up.
Thank you.
Yeah, we've mentioned that a lot in these, haven't we, Phil? We tend to talk about that a lot.
And one last thing, I don't want to hog this one, but that is my thing with statistical significance in clinical relevance. And just because the authors, I don't want to say it's a bad study. I just want to make sure that people interpret it the right way. And they don't that last line with the p-values. So
yeah.
I know I'm not one of the guests, but
no, add whatever you want. You're welcome.
Because I see my wheelhouse is baseball and golf, both obviously rotary sports. And I think, although, maybe not clinically significant, and I think it's a good jumping off point of a good topic of conversation that is pretty critical in these athletes. And what I see, this was done kind of to simulate like a 9 innings pitched type of situation. But if you look at pitchers over the course of the season, especially when you start talking about professional level and the amount of strain that they put on their body, and look at their thorax as a whole, what I tend to see in my pitchers is they start getting a lot of dysfunction, a lot more so in their rib cage than their T-spine. And I think we kind of beat up the T-spine a lot. And they really start getting a lot of rib cage dysfunction and oblique dysfunction and things of that nature. And they constantly feel tight, but they're actually usually very hypermobile. And so that foundational stability stuff is usually what we end up focusing a lot on. And so I'll do a lot of screening on the front side of the season and really kind of hammer home the importance of their stability and motor control exercises that they do pre-game, pre-throwing, so that they stop getting into that cycle of I'm tight, and they just want to go to the team chiropractor and just get manipped, and then they feel better for a day, and then they're back to square
The
one.
same problem.
Right.
Yeah.
So I think like, although maybe the study, we didn't walk away from this particular paper saying like, this is a life altering, we're going to change the way we practice thing. I think it's a good conversation point for these types of athletes.
Yeah. Great comments.
That was
Absolutely.
What?
if I could throw one thing out there too.
Yeah, you got it.
I was on the same boat. I'm sorry. I just think it's if nothing else, it just draws attention to that thoracic rotation. I mean, there's been a couple of studies, the segmental power analysis from like Evanaldo and Escamilla saying that trunk motion accounts for 86% of fastball velocity. So even if it just, puts it out there like, hey, we should be looking at this, maybe you would just cast a wide net and see some people who may be lacking in mobility or control or whatever it is, but at least it's a talking point and brings it to the front of people's minds. There's also the data that says that youth athletes are less, they get less rotary power than professionals as well. So, something we can start looking at early on. So again, I at least like that we're putting some attention on. I think it's good.
So Matt, you bring up a good point. Like, do we think that, because I think a lot of us on this call will say, yeah, we definitely look at that. We think it's really important, but do we think that's not well, I think I know this answer. It's not the norm, right, in the population?
Yeah. I mean, I think it's one of those things. I always say that injury prevention and performance enhancement go hand in hand, right? And if somebody's trying to maximize their performance, they're going to be, try to throw as hard as they can. There's enough data that correlates trunk rotation with velocity as well as trunk rotation with elbow valgus force that I think we can kind of look at trunk rotation and say, this is potentially low-hanging fruit that we can look at across the board. And it could be a quick screen if we can figure out a good way to look at it.
One last thing I want to add on the I guess the critique of the article and how it was written for those who are interested in being a little bit more critical of the assessment is one of the things I noticed was that they use recreational players and their speeds averaged about 54 miles per hour or something like that. And so these aren't high level athletes. Yet they were quoting research and comparing their results to high quality athletes. And we know that high quality athletes just move differently. They have a different pattern. And so when you're trying to use research and apply it into your practice, the first thing you need to look at is what is this sample? Is the sample representative of the athletes you're working with? And if you're working with recreational players that are throwing in the mid 50s, that's fine. But if you're working with high-level professional athletes, you need to look at this a little bit differently.
Great point, Phil. Yeah, and they threw like 135 pitches, which for a recreational person, that seems kind of high to me. I'm not 100% sure about that, but that seems like a lot of pitches.
That's high. Yeah.
For a study like this. Yeah, in a short period of time. What did you guys think of the thoracic rotation decreased over the innings? What does that, so if it decreased, I don't even remember which way it decreased, or if they just looked at the total rotation of it. So what decreasing the rotation, is that horrible? Does it occur? Is this a normal occurrence, kind of like the asymmetries? Is that normal that you have a little decrease of rotation over the course of the innings, or is this different because they're recreational pitchers versus professionals?
Well, I think Rob, you bring up a good point. The first thing we have to look at is they're looking at that thoracic rotation specifically where they saw the slight decrease was at stride foot contact. And so at stride foot contact, if I'm a right-handed thrower, stance limb is my right, lead limb is my left. As soon as I hit, there's certain things that should be going on from the front side with the hip, with the glove side, with the knee bend, all of that stuff. You should not be fully open at that time. You don't want to leak all your energy out the front side too early. And so that thoracic rotation should be a little bit, again, if I'm a right-handed thrower, it's going to be rotated to the right slightly. And so what they're saying is that, that they saw that decreased a little bit, very minimal to start with.
It may not even be, again, may not even be clinically relevant. Yeah.
Right.
That's where we went back to the hip shoulder separation. It's not just look at the shoulders. We got to look at the hips as well. And another thing to look at is when I look at the tables, and a lot of times another thing for you guys that are interested in reviewing these, look at the tables and the actual data. And the things that are interesting is that they actually found this significant difference in a 2-degree change, but not in a 5-degree change.
Right.
So one of the things that you need to look at is when we go back and talk about this significance thing, it's very influenced by the variability. And there was a larger standard deviation, one of the groups. So that leads you to think that there might be more variation that really isn't clinically relevant. So that was one of the things that I like to recommend to people. If you really want to get into this, go into the tables and look at the actual differences rather than just those p-values.
Great points, Phil. What did you? I've seen the muscle endurance assessments they did. I've seen the extensor test they did, and I've seen the side plank. I've never seen that flexion test before. Have you guys seen that?
I think that was I went back and looked at the citations. It's another thing for review. If you go in and actually look at the citation, they actually did the flexion and extension in one. And Stu McGill was one of the authors. Was the lead author on one of those papers. Very reputable in terms of looking at back endurance. And so these were tests that have been done on probably less on the athlete side, but more of that low back pain.
Yeah. The flexion test has been done a lot too, Phil, when you looked it up.
I did in that one paper. I don't know if it's been done.
Okay. Yeah, I've never seen it before, but it looks really pretty simple. I mean, it looks pretty simple to perform and pretty easy. And maybe it's one we should try out a little bit. General, you got any questions about this study? Or are you just going to sit in the silence there with your camera off?
I'm just listening and learning.
Just listening and learning. All right. So did the trunk muscle endurance decrease in this study because of any issues, or does it just happen? So it's another question I had really was, they found the endurance decreased. Is that, again, is it normal for it to decrease after 9 innings? You think maybe it would be?
Yeah, I think we would probably expect that, right? I guess one of the, and Phil, you may be able to speak a little bit about the design with this. I guess one of the issues that I have with this is we're looking at an isometric muscle endurance, right? And these are ballistic movements where we're eccentrically and concentrically moving. And so how relative is it with an isometric test? From a design standpoint, Phil, I mean, what do you think?
Totally agree. That was one of my, again, critiques of this, is that test really isn't representative. This is not an endurance necessarily activity. Pitching does have endurance, but it's going to be more of that power, that high velocity, and the endurance of a time test, which is probably 30 seconds. Really, I don't think represents the actual endurance over time of multiple repetitions. It's one single hold. That's a great point that you bring out, Craig, for sure.
To their cause, what test would you use? What test is more dynamic that you could use to test trunk?
What I'm thinking
endurance.
Is what you and George have done, which is a lot of that plyo ball stuff.
Yeah.
Right? And just looking at how you guys were doing that repetitive throwing, that would be more indicative of what you're looking at here.
It's like maybe an overhead where you're using some trunk motion with it, overhead plyo ball distance, or something.
Medicine ball.
Yeah, Rob, we use, and I don't love it, but as part of our return to competition with our pitchers, is we've got a plyo ball endurance. It's not an endurance test, it's for a minute, but they're doing ballistic movements over and over for a minute to see what their overall output power is. Again, I don't
count the number of reps with a certain weighted ball,
the number of reps. Yeah.
So how do you do it? What do you do? You're like throwing side throws, or what are you doing?
So we actually do straight down, and it's just from a control standpoint, just because we don't have a big, and where we're doing our testing, we don't have a big concrete wall, but we do straight down throws. Again, I don't love it, but it's
better than nothing.
It's a question that we have as far as part of our return to performance is like, is there any relationship there? I'm not sure that there is, but one of our researchers wanted that piece in there, so we're kind of looking at it.
Yeah. No, I like it. It's a good idea. I mean, it's maybe more replicative of what they're actually doing or what they're looking at. We have a question from the audience from our buddy Andre. Phil, Andre, is he sitting beside you asking this question, or is he actually somewhere else?
He's in New Orleans.
He's New Orleans. Okay. We've seen that our pitchers don't hold their hip shoulder separation as long later in the game. Later in the decrease the time they keep their hip shoulder separation during the pitch. So we feel they see a decrease in velocity. So yeah, once again, I guess it's not really a question.
That's typical.
Question and answer. I guess Andre answered.
Difficult Andre question.
Yeah, yeah, typical Andre question where he's answering something for us. Yeah. So we can reply, we can respond, whatever you guys think. But
here he goes. Chat is
oh gosh. Okay. All right, Phil, do you got anything else on this one, or do you want to move to the our second study?
Do we need to address Andre's question or comment?
Well, it wasn't really a question. That's what I was saying. It's not. I don't think it was. He was just telling us more than a question.
I think I fixed the chat. I don't know. Someone can try and type in there, but we'll see.
Oh, do you all agree? So his question was, do we? I'm sorry. So there is a question. It just came 3 questions later from Andre. He's not really picking up the question and feature that well. IJSPT would like to answer this question. He's getting more, but now he's just getting downright rude with us, which is crazy. Now his question's gone. Where's that? Here we go. Okay, so Craig, do you agree? We've seen that our pitchers don't hold their hip shoulder separation. Yeah.
Yeah, and I think that's why we see, I mean, it's so hard for these individuals that come back. Let's say they've got a UCL they're coming back for. And so we'll get docs that say, why in the world is it taking you 10 to 14 months to get them back? The pitching motion is so difficult. It's all the timing and sequencing. It's such a complex movement. So yes, I definitely believe we certainly see that. And as Matt mentioned earlier, as we start to see those mechanics change and that separation, that hip shoulder separation, then we start to see those changes that take place at the shoulder and elbow as well. Those forces get really high.
Yeah, great question, Andre. We're just giving you a hard time. You know we love you, man. Thanks for shooting questions our way. All right. Anything else, Phil?
No, that was good.
You're good. Matt, you got anything else before we go to your study? You got the generals. The general's gonna go on you hard for this study that you have, because he's into upper extremity functional testing. So I hope you're ready.
Hey, this is the whole reason I wanted to be on, is to hear the general talk on this.
There you go. There you go. All right. So the next article, Matt, I didn't even have you introduce yourself. Go ahead and introduce yourself real quick, Matt, since we're getting ready to talk about your paper.
I'm Matt Gothier. I'm up here in Chicago. I am faculty for University of Illinois Chicago's PT program, as well as director of their sports residency.
Great. Thanks, Matt. Thanks for joining us tonight. Matt's paper is entitled Missing the Forest for the Trees, a Lack of Upper Extremity Physical Performance Testing in Sports Physical Therapy. Matt, can you give us just like a brief rundown of your paper, kind of background, purpose, results, things like that?
Yeah, I mean, I think what it comes down to is we've seen all these articles on lower extremity physical performance testing and how it correlates or doesn't with return to sport or re-injury rate. And there's just not as much time or resources spent on the upper extremity. And then it became a question of, why is that the case? Is it because people don't use them enough to even do the research? What is it? So we wanted to see what people are using, if anything at all, and if they're not using things, what barriers exist, so we can either figure out how to remove these barriers, or if nothing else, shine a light on what we suspect to be a problem of too few people using the test. And we were right in that under 50% of clinicians are using any sort of physical performance test in making a return to sport decision. Sports specialists, it's over 70%, but your non-specialist clinicians, it's around a third. So that was our big thing, was hopefully shine a light on the issue that we're not using these tests and we're not getting a full picture of the patient's function, and see if we can figure out if we can remove any of these barriers that exist.
Yeah, thanks, Matt. I found this really interesting, and I mentioned in the questions that I sent you guys, I was really shocked that less than 50% of people use any form for the upper extremity, which seemed horribly low to me. And I mentioned that I think it's more than likely it's probably just because 25 years ago I did my fellowship with the general, and it was just drilled into me that we do functional performance tests for both lower and upper extremities. So, General, what do you think?
I agree. I think.
I mean, in a few
firstly-
words, I agree.
Yeah, firstly, Matt, great job. You had almost 500 participants that responded. So that's a great response rate. And as you indicated, I think the biggest take-home message was the barriers that were identified. And ironically, the number one barrier is people don't understand the literature. So that's the first thing. And again, when we're getting very few people back to sport and then back to their performance level is even less, and the re-injury rates are high, it's amazing to me that people aren't using something. But nevertheless, out of the barriers, which I found really amazing, yeah, the lack of understanding of the literature, but over half of the people said a lack of equipment. The irony of that, the most commonly cited upper extremity functional test in the literature is the upper extremity closed kinetic chain stability test. There's over 100 publications that have cited that article, and that takes 2 pieces of tape on the floor and your phone as a stopwatch. You got to be kidding me. Furthermore, they said they're limited with time was a big barrier. That test, 15-second test, 45-second rest 3 times, 3 minutes. I mean, it's just amazing to me, some of the excuses, sorry, but we use as therapists. The other thing that I think was interesting at the very conclusion, the discussion came talking about maybe in the sports specialty residency, one of the most important criteria are return to sport. But again, we can't reserve criteria for return to sport to the residency level because there's so many. How many SCSs are there? Less than what, 2% of the entire profession. And yet many, many physical therapists are returning people back to sport on a regular basis. And the last comment I'll make just to get things started is, again, if only 1/3 of non-specialists are returning people back to sport with no functional testing. And there's a study by Creighton in the Clinical Journal of Sports Medicine in 2010, and they state if a physician, physical therapist, or athletic trainer returns an athlete back to sport and they get re-injured, they can be held liable. And again, to be returning people back to high levels of sports with no criteria whatsoever for functional testing, to me, frankly, is a very litigious situation. So just a few preliminary comments to get us started.
Have you guys just off of George's last note there, have you guys heard of anybody getting in trouble legal wise because of not doing testing? Anybody? No.
Not necessarily for testing, but yes, for returning
When
patients
someone's not
back.
ready. Yeah.
Ironically, I don't know if you guys have seen on social media, but an NFL football player has actually sued Dr. Andrews for an ACL. Now, who do you think is going to be on the expert panel for that one? Holy mackerel.
Yeah.
Yeah, that one's
But
in my
anyways,
town.
It happens. Yeah, it happens.
You have, Ashley? You have?
Yep.
No, that case is happening in my
Oh,
town.
Yep.
Oh,
That's
okay.
Yeah.
one of our
And
guys.
I do know physical therapists who have been sued, not necessarily just for functional testing, but for
Yeah,
other
yeah.
things.
Yeah.
So,
No, I did look at a case once where a therapist got sued because the person, the patient went back to activity and got re-hurt, and said that the therapist didn't do well enough screening when they let him go back to activity. I actually thought the therapist did quite a bit of return to sport testing, but the patient and his lawyer didn't agree with that. So it does have, this was in someone who tore their ACL. So it does happen. So I'm assuming it could happen in the upper extremity as well.
the other paradox that we're facing is, again, even the majority of people, even if we set up these criteria, and that same thing applies in the lower extremity with ACLs, which there's tons of data on, that even if we have these criteria, the majority of individuals don't pass them anyhow. There's only 25 to 37% of the individuals even pass the tests to begin with, and yet we're returning them back. So if they don't pass the test, what do? Keep holding them out forever? We can't do that either. And that's a dilemma both for the lower extremity with our ACLs as well as for the upper extremity. And the upper extremity is 10 to 20 years behind. And that's why I really applaud Matt for some of the initiative that he's taken, really to looking at some of this upper extremity functional testing. And, you know, the last caveat, which we just presented at CSM, is there's nothing in the literature right now with upper extremity neurocognitive reactive testing. And we had two papers, two research posters at CSM, and one of them actually won one of the 10 best awards for posters at CSM. And it didn't win the blue ribbon, but it was nominated for one of the 10 best. But nevertheless, we have now established at least the reliability of closed kinetic chain neurocognitive reactive testing and an open kinetic chain neurocognitive testing protocols. So we at least have started to be able to show there are ways to do the testing. Now, again, we don't know if there's a correlation, and even if they pass those tests, is that going to mean anything? That's what we got to start somewhere. And if we're starting with testing, we got to start with reliable tests. That at least we've done so far.
Yeah, good job. Good job, George. Good job on the answering the questions, and great job on your paper that won the award. So tell me, guys, George mentioned this briefly, the is evaluating return to sport. Is that the paper alluded to that it is, you know, we do return to, we evaluate activity. It is an entry level skill for PTs, but is return to activity for sports an entry level, or is it something that maybe is a little higher level? What do you guys think?
I can tell you a little bit real quick. First of all, Matt, great job on the survey. As George said, to get that response rate, you did a phenomenal job. You did survey, you were narrow in your survey to sports physical therapists. And the largest number, interesting, were the internationals. I think you had 14,000 names there. But that leads to, Rob, is the fact that there are a bunch of therapists out there that aren't sports being, you know, they're not sports section members, they're not sports whatever. And what I was thinking, as George was saying, and I agree with you, George, about this is BS, lack of time, lack of equipment. You know what I think it comes down to is that the doctors aren't asking for it. And I think that if the physicians were asking for it, that would make a huge difference. Because what do they want now? They want functional testing for ACL and all that other stuff. So I think we've got a little ways to go, but you guys were the pioneers in upper extremity functional testing. So kudos to Matt for bringing this to light. And I think we have a long way to go.
There have been a couple of studies recently. One was in Journal Shoulder Elbow Surgery by Wilson, and they actually did upper extremity functional testing along with all the other impairment things. And they made the big issue of, again, patients who had Bankart repairs, that they were not passing the tests. Likewise, just recently in AJSM, there was a great article on Latarjets. And for the first time, I've seen that they're doing functional testing as criteria for Latarjets. And they actually have the pictures of the closed chain test and the seated shot put in there, which I thought was fantastic. At least it's heightening the awareness that, hey, we need to be doing something. We don't know the best way yet, but we need to be doing something. I mean, let's face it, we've been dealing with ACLs for 50 years. And Tim Hewitt's meta-analysis of meta-analyses has shown that there's no consensus or a validity for prevention of re-injuries. That's 50 years of ACLs, and we're still struggling with it. I mean, Craig has done a lot of work in that area, looking at some of the power aspects and some of the rate of force development and all these things, but we still don't have anywhere near a consensus. And even if they pass these tests, there's nothing. I mean, it's in high level sports, it's a 30 to 40% re-injury rate with ACLs. Nowhere else in orthopedics do we accept a 50% return to sport, about a 30% return to performance levels, and a 30 to 40% re-injury rate. Nowhere else in sports nowhere else in orthopedics do we accept stuff like that. And yet with ACLs, that's happening. And I think the shoulder's further behind. And there's several studies. Bradley just did a podcast for AOSSM. They just did a 10-year follow-up on their posterior instabilities. And again, they said their conclusion was they do great. Well, hell, there was a third of them had re-injuries or had to couldn't participate. Come on, is that a good
do
return
great?
rate?
Yeah.
You got to be kidding me.
Oh my
Hey,
God.
George, they were doing great when they walked out the door.
Yes.
That's right.
Great. Yeah.
Oh
Yeah.
man, I'm telling you. I think it's really interesting how we document our successes. Oh boy, I'm telling you.
Yeah. Posterior
But
instabilities are
nevertheless-
tough. Posterior shoulder instabilities are tough though.
But I think the value of Matt's article is he brings the importance of the functional testing to light. And then if people really read that article and they realize, good grief, I'm not a specialist, but again, I'm not really doing the testing. Something's got to happen. Something has to happen.
Yeah.
And again, I
Yeah,
don't know
George,
what.
you've always taught, I know you've always taught me and you've taught hundreds of thousands of other people that, you know, you got to test something. So if we don't know the exact sequence of testing that we need to do yet to show, or to be able to definitively say it may decrease the risk of injury or it's going to help them get back to return to activity, at least test something. I mean, it's better than not testing anything. So you at least got something to back your decisions versus time or just saying, you know, I think they look good.
Test, don't guess.
Test, don't guess. Yes. I learned that
That's
a
been
long
my-
time ago.
Been my mantra for 50 years. Test, don't guess. Because I'm an NATA member for 50 years. So I've been saying that for 50 years. Test, don't guess. And we really need to be doing that. We need to do a better job with it. But as I said, I think Matt's article was an outstanding article that really, if nothing else, brought it to the mainstream attention. Because the beauty of IJSPT also is that it's open access. And to me, that's one of my favorite things about the journal, besides all the quality of the articles. It's open access, so everybody can have access to it. It frustrates me when I read an article or an abstract of an article or whatever, and I want to get the article and I can't get the damn thing. But having open access really, I think, is a nice contribution to the professions to be able to read the information, understand it. And hopefully the biggest barrier was 59% of the people said lack of understanding of the literature. So hopefully reading this is going to make them more aware that the second biggest barrier was lack of equipment. That's over half of the people. And as I said, the most commonly cited closed kinetic chain upper extremity stability test with over 100 references, you need 2 pieces of tape on the floor. Come on. How much equipment do you need? Doing a medicine ball, single arm seated shot put. All you need is a medicine ball. Almost every PT clinic has that. Every athletic training room has that. So again, I don't think they're very substantial excuses.
Yeah. So Craig, tell me, we got kind of a little bit off of a tangent there. Is testing the upper extremity functional testing, is that expectation? Is that too high for entry level skill?
Well, so yeah, it's a great point because I was going to ask you guys that. So from a standpoint of, so I'm pretty spoiled in the culture that I'm in, is that our physicians, our PTs, we all just understand that that's what happens, right? It's an expectation where we're working together collegially. And so the physicians are really determining, in fact, they're making clinical decision-making based on what our tests are, right? And so we're giving this data and saying, hey, Dr. Conway, this is what we found. And he's using that to say, okay, what do you think? Are they ready to go back? And we're saying no, right? So the question is, like you said, is that with everything that goes on in the entry level, I mean, you guys know what this is like much better than I do. Like there's so much you have to get in.
Yeah,
Is there a place for that within the entry level curriculum?
I think there is, because we talk about it in our program.
We have a day that's devoted to return to sport.
So, but that's a great point. So you get one day, right?
Yeah, and I don't even.
And I only have a few hours.
Yeah,
we have a few hours. Yeah.
I think
Well,
this is where we're talking about this at Belmont. about, do we start going more towards having some specialty track options where you have some elective things? If you don't want to be an orthopedic or sports PT and you want to be pediatrics or acute care or neuro, like, can you take some additional hours in something focused on that and let the people who want it, like maybe you do a whole, elective on return to sport testing for the people that really have this strong desire. And I think trying to have some specialty tracks within the curriculum within the DPT programs versus relying on residencies and fellowships, which not everyone can afford to do or is capable of doing, is going to be important.
I know Matt does that up at Chicago because he had me on as a guest speaker one night, but we also have the specialty tracks. And as you said, Ash, that's a great suggestion. And I do a sports PT special track, and we do cover it there. But I also cover it for a few hours to all the students in their X class. So
I think it's nice.
Extremity.
Yeah.
Craig, go ahead.
Oh, sorry. So I'll just tell you, in our system, we have 14 residents that come in. So eight ortho residents and then 6 sports residents every year. And it's really nice that those individuals that have come in from schools that have at least heard about the return to sport testing, because at least they have some understanding coming in. And so I think, to your question, Rob, I think if there's any way of, I think it's got to start at that grassroots level, like early on.
Yeah.
And as I said before, if for no other reason, there's only 1/3 of the therapists who are non-specialists who are doing the testing. And yet, every day in the thousands and thousands of clinics across the country, some of these non-specialists are making decisions to return people back even to recreational sports on a regular basis.
They have to be.
So again, if they're totally naive about it, man, oh man, I think that sets up a lot of the patients for poor performance and potential re-injury. So again, as you just said, Craig, I think it has to be introduced there. And again, admittedly, it's one of the premier criteria in the residency program where you can really delve into a lot more depth. But nevertheless, I still think it has to be exposure to everybody because there's many, 1/3 of the therapists aren't using anything.
Yeah, crazy.
And that's
crazy.
where, I mean, every musculo class has hop testing as part of their lower extremity unit. And we all know that hop testing has their warts. I mean, at a bare minimum, expose them to the closed kinetic chain extremity stability test. I mean, if you're going to include hop testing, have at least one functional upper extremity test. Again, just expose, maybe they don't use it, but at least expose them to it. We should get in that habit.
Yeah, no doubt. No doubt. Hey guys, we have some questions from listeners. Our first one, I think this is more of a statement again. Sorry, guys, but I think this relates to what Craig was describing with his clinic from Holly Hennessy. It would be great for MDs and surgeons to rely and lean on and ask PTs for info related to return to sports tests. Oftentimes, the docs are releasing based on time more so than actual criteria. And that's, I think, what you were alluding to, right, Craig, that your doctors are asking you, they're wanting to know your test. So you're probably in an environment that's maybe different than a lot of other people, where you're very fortunate that they're asking you for those type of things, where others may not have those same type of doctors.
Yeah, no, absolutely. And I think we've all been in situations where we've had docs that are on board, other docs that are not, right? I think to the point of this, like even within our system, we have something called a PT first model that our executive leadership team has actually embraced, is that they're seeing the value of the PT to kind of drive this decision-making throughout the system, which is we're trying to take advantage of that and use that to help kind of educate the rest of the healthcare system about what PTs do. We're seen as the primary care musculoskeletal specialist, right? So.
Yeah. Andre's back on with another question. This one is actually, I think this is actually a good one though. I'm teasing Andre. Do you think that clinicians familiar with the sport are less hesitant to do return to sport testing on the field, on the court, or on the pitch? I feel that some of this is hesitation to stress or test the person because of fear of failure. And I think there's probably, if they don't understand the testing, they don't understand how to do the test or what they're doing the test for. I think Andre's exactly right. They're going to be fearful to test somebody. Wouldn't you guys agree?
But you mentioned it before, Rob, and as you learned a long time ago, that's where you use a functional testing algorithm or a checklist sequence. So again, you don't put a patient into a situation that they aren't ready for. And you can determine that is by setting up different criteria. And if they pass that test, then you basically establish a higher level criteria. So again, simply when you're looking at the lower extremity, which everybody's more familiar with, you would do a single leg hop. Then you might do a triple hop. Then you would do a crossover hop. Then you might do something like a T-drill, which is multiple hops and anterior, lateral, and retro hopping. Then you can start adding the neurocognitive. I mean, so again, back to that question, I think it's simply a matter of setting up a functional testing sequence or an algorithm and a checklist, and that carries all the way into the field. Now, obviously, part of that, as we all know, is kinesiophobia, well documented in the knee, but there's also the index now for the shoulder instability kinesiophobia index. And again, so that needs to be an important part, because if they're apprehensive in a controlled clinical environment, then they're going to be even more apprehensive going out into an open skill setup where there's the sporting activities. So again, it's a progression of going from, I think, the clinical setting to the ecologically valid setting, which is what they're doing in their sport. And it needs to be a systematic process. That's how, at least that's how I get around that.
George, you just described, just a moment ago, you described like a functional testing algorithm for the lower extremity. Since we're talking about upper extremity functional testing, can you give people just like a taste of how you would start out at a low level and progress to a higher level with upper extremities?
Yeah, we actually have a paper that's being that's already accepted, and it's in print on upper extremity open kinetic chain testing. And then we have another one that we just submitted on closed chain. So the first thing in the upper extremity, we stratify the subjects into either open kinetic chain activities or closed kinetic chain activities, jiu-jitsu, wrestling, football, things of that nature, contact sports, collision sports. So with say with the upper extremity as an example, one of the sequences that that's in press as we speak, that we basically took a lot of the things that Dr. Andrews and Kevin Wilk have done over the years. And again, if somebody has an arm slot where they're pitching and they're doing a sidearm, then we're doing a prone medicine ball drop. Now, we've done all the impairments, the range of motion, and all those kinds of things. So we're going to the functional testing. So that's one of those first functional tests we may do with them. And then if they're a throwing slot here, then we may do a ball rebounder type of a throw. Then from there, we might progress to a plyoback type of a throw. To start actually bringing in the entire body as a sequence. So there's 3 sequences right there that we would use as an example for doing something for an open kinetic chain. Closed kinetic chain, basically, and then ultimately with that, we would add that neurocognitive reactive now that we know there's reliable testing. Closed chain, we would basically start with the simplest test, CKC upper extremity stability test. And then you could also, again, I think even easier than that, frankly, as Craig had talked about before, a medicine ball, doing what's called a medicine ball shot put test. You can do a single arm, but you can also, for a closed chain, we typically will use more of a heavier medicine ball with 2 arms. Then we can go to the push-up release test, which is what the military is going to now. Instead of doing a regular push-up, which is frankly a plyometric, because when you get down into the stretch, shorten cycle, it's a plyometric. So the push-up release test is really more stressing concentric power production. So doing a 2-arm medicine ball, doing a push-up release test, and then going either before or after into the CKC test, and then the neurocognitive reactive testing. That's a sequence that we would be using.
Great, thanks, George. That's excellent. I think that will help a lot of people if they're not aware of that and haven't used those. Another question on sent to us by Katie Bigsby. I'm not sure when this came in, who was talking when this came in, but she said along with that, and that's what I'm not 100% sure with what she's talking to about along with that. Any suggestion on how to get some of the surgeons on board with having a PT help them build their protocols if they're going to insist on having such a strict protocol. So how do you guys go about getting your surgeons on board with you and the protocols that you use with your testing?
Rob, I think this came in when we were talking about how we would try and engage the physicians, right, in making some of these decisions. And I think all of us on this call know that physician relationships take time, right? So I remember when I first got out of school, it took a long time. I spent a lot of time with physicians, sometimes on my days off, sometimes whenever I could get in front of them. And I will tell you that, for instance, John Conway, he and I met about 25 years ago, and now we're still working together today. But I spent many Saturdays with him, going to his injury clinics and doing stuff like that. That's one of the things that I know that sounds old school, and maybe maybe we don't want to put in the time, but to really have those relationships, you've got to get in front of them. And I think the other piece of it is that we encourage our young clinicians to obviously get in time, spending with them in surgery, within clinic, and just asking questions, but also to be very proactive in asking questions about things. Like, rather than sitting back and waiting on the physician, is we take some stuff to them and say, hey, I've been working on this. Can you give me some feedback? Even though we think it's good, let them make the decision that, oh yeah, this is pretty good stuff.
Yeah. So don't wait, be proactive about it. Don't force it on them. But yeah, just show them what you have available, and let them with you decide maybe what is best for you to test. Yeah. And I agree with you 100% about the relationship. It just takes time. I think some of it is kind of luck also, maybe. I mean, maybe you get, it can really be almost like a make or break. You could see like the first, let's say the first 10 patients of theirs, that they do horrible. You may have a hard time, getting in really tight with them. But if you're lucky enough that you get 10 really good patients, then you've made Ellenbecker taught me this one a long time ago. You make a silk purse out of a sow's ear, and sometimes that works out for you, and you get a good relationship. But so it's time.
Now you also
effort.
know why Rob left lacrosse, those first 10 patients.
Got chased out. Yeah.
That's a good point though, Rob, real quick on, you do have patients that can make or break you, that you do whatever the same, and they're just not going to respond the way that others would. And you really, and physicians are lucky enough to be able to choose the patients that they want to treat. We don't always have that luxury.
Yeah.
So they can choose the ones that are great candidates and they'll do well. And then sometimes you get the cream of the crop, sometimes you don't.
Yeah. Katie replied, thanks guys. I did get lucky in Cincinnati with residency, but I've not built those relationships back in Michigan. So I'm guessing that's where she's at now. I'll work harder on that. Thanks. So great advice, guys. And Katie, just keep after it. Just keep plugging away. It just takes time, and you got to put in the time, and you got to put in the effort. And I think if you're persistent in time, it will be fruitful.
I think also looking at some of the more current literature, because as I said, there's articles in Journal Shoulder Elbow Surgery and AJSM where surgical procedures are now using some of these functional tests as part of the criteria for return back to sport. So if the docs, frankly, aren't familiar with some of that, then occasionally when you go in to meet with them or whatever, kind of drop an article on their desk to remind them that the current literature is in fact starting to head in that direction.
George, I think you bring up a great point there. I will tell you that's something we do with our physicians where we are. Obviously, we have an orthopedic surgical fellowship, sports medicine fellowship, and so there's a journal club each week that all of our physicians are on. And Lane and myself will drop articles in there that are very specific. And it's so funny. The physicians will come back and say, hey, we should start doing this. And then we'll be like, that's a great idea. Let's do that.
That's the other key right there, Craig. Plant the idea in the physician's mind, and they end up turning around. Hey, that's a great idea. Why don't we do that?
Yeah.
like they have ownership of the idea. So that's the way to get them on board. They think they have ownership of the idea when you've planted all those different ideas.
Hey, it works. It works.
What a buy-in.
Yeah.
It works. What do you got, Ash? We got like 4 minutes. Any closing comments?
No, I just agree with all that. It's amazing. In the almost 10 years I've been with Dr. Bird, the amount of brilliant ideas he's had. But
that may have started somewhere else. Yeah. Amazing.
But that's
he
a great
seems like a pretty
example,
nice
though.
guy, though. He seems like a pretty nice guy. The
No,
couple times
he's
I've met
very-
him,
yeah,
he seems like a really
Dr.
great guy.
Bird's-
With
Dr. Bird's rule of thumb is he never wants to be the first or the last to do something. And so as long as I can kind of slip it in there and be like, here's what other people are doing, then we can usually finagle our way into moving things along. So,
yeah.
but no, he's great. He's very, very, very Dr. Andrews-esque, obviously trained under him. So very PT friendly, understands the role that we play, and we're very respectful of the role obviously he plays. So.
As Dr. Andrews always says, don't be the first to make the big statement.
Mhm.
Always have somebody that is going to basically lead the way so you don't get in trouble with it.
Looks like we have a question in the chat. Is there a database you recommend for resources where we can find joint-based functional testing documents? Example, return to practice criteria for shoulder injuries that includes subjective areas, PROMs, objective, functional, clinical judgment, etc.
I'm not sure about all those criteria, but as I said, there's 2 papers that are actually, one is in press in IJSPT on the criteria, and it shows the reliability and some of the validity of some of the criteria for the closed kinetic chain testing. And then we have a second paper that's in review, or it will be in review here within a week, on the upper extremity. And so I think that's going to provide a lot of the sequencing of some tests. And most importantly, it provides the reliability that if we do any testing, we got to start with a reliable test. So both of those are going to be, and hopefully will be, well, one is in press, the other one hopefully will be accepted. And that should answer a lot of the questions. And again, in IJSPT, because it's open access, that allows all clinicians to read the material and then to use it.
You just got to sign up.
This
All
is
you
a
gotta do
great
is sign
follow-up.
up. Yeah.
This is a great follow-up to what Matt taught us tonight, that there's too little information about upper extremity testing from the outstanding study that he did. Now, some of these other studies will hopefully follow up and fill in some of the gaps.
Yeah. And 2 things on that. One, thank you for reiterating the open access piece, George. I don't know that everyone even realizes that. So everyone just keep an eye on your emails, because as soon as we'll have a June 1 issue coming out here soon. And then the other thing is, like, I think this is something I really reiterate to my students and my new grads is, like, something is better than nothing, right? Like, you know, trying to have this perfect protocol of return to sport testing, and when you get so overwhelmed that you just scrap the whole thing, that's no good. Like, I'd rather you at least do something, right? Like something that then opens your eyes, that maybe spurs like kind of that moment to say like, oh, maybe then I should look at this. And PTs are like, you're by nature, you got here because you're intelligent. So sometimes, you know, we're kind of looking for that perfect protocol, but I think you got to start somewhere. So I think just, you know, even if you take one piece of something you learned tonight and start applying it, and then that will open the doors to more.
Yeah.
Test, don't guess.
Test, don't guess. All right, guys. Thanks everyone for being on. Craig, appreciate you hopping on with us, man. Good to have you.
Thanks for having me, guys. Great.
Yeah, we'll have you
Appreciate
again in
it, Matt.
future.
Great
General.
work.
Yeah, General, thank you. Matt, thanks for presenting your paper for us. Thanks for publishing it with IJSPT, and we look forward to more of your work in the future.
For sure. Thanks,
Thanks for
everyone.
having me, everybody. I appreciate all the kind words. I'm glad
Great.
it's showing the light on what I wanted here, to light a fire under some people's asses, to put something good out there
There
to
you
guide
go.
some people.
There you go. Keep it up. Keep up the good work.
I want to reiterate
Great job.
the general and Ashley said, is that this is open access, but it's only through several of our sponsors.
Yes.
You know, we don't require publication fees because that's the way that our journal works.
Yep.
So please continue to support our sponsors, because that's what allows us to be open access. And George is right. That's such an important barrier to getting the information out that we take very seriously at the journal. And thank Ashley for being a big part of all things you do for manuscript review, because that's another volunteer thing that all of us here volunteer our time to make the journal work in open access.
If anyone else that's still lingering on this here as we wrap up, if anyone has an interest in reviewing, you just reach out to me.
Yeah, let
Even
us
if you have
know.
0 experience, we do not care. We will help guide you. So that's how we get these papers published. But yeah, June 1st, new issue coming out, lots of good stuff in there. So, and then we'll be back here in June, and we have our updated dates through the rest of the year for Journal Club. So next email that comes out, we'll have all those on there to mark on your calendar. But
And I think Ash, I think we're gonna excuse me, we're gonna try a little bit of a new format, I think. I don't know if Mike's talked to you or not, but we're gonna try to get like a guest therapist like Craig. And then also one of his favorite doctors to hop on with us. So we're going to have like a team of the special guest and their doctor that they work with on the session with us. And we'll still do, we're trying to decide for sure whether we're just going to do one IJSPT article and maybe one article that the doctor would like to choose from any journal he would like, just something of their interest that they think would relate to therapy and rehabilitation. So
Or
I
an
think we're
article,
going to,
why don't you consider an article that the PT and the doc publish together?
that would be fine. I think that
I mean,
would be
that
perfect.
would really be a great example of the camaraderie and what they're trying to really promote.
Yeah,
Instead of
no,
just
that would be great.
arbitrarily picking articles. So
I think that would be fantastic if we could
Walter,
get those. We just need to get those people to agree to doing it over our next several.
I got
several
July
podcasts.
taken care of. I got
You got
So-
July? Yeah.
Craig and Dr. Conway just volunteered for the next one too.
Yeah, it may be August. Yeah, August.
There we
I
go.
guess.
There we go.
awesome.
So, hey, Ashley, you got someone. Look at that.
I got it. I just copied
know.
her email. I copied the email out of there. I'm going to email you now, Trish.
Awesome.
All right.
All right,
Thanks,
guys. Have a good
everyone.
evening.
There's a
Thanks for
question,
joining everybody.
in the Q&A is asking.
Thanks.
There's a question in the Q&A
Thank
is
you.
asking for the best way to get in contact for reviewing.
Oh,
Oh.
okay. Perfect. Thank you very much. All right. For those still asking about that, I'm going to put my email in the chat real quick, and you guys can email me. But other than that, you guys feel free to jump off if you're done. But yeah, anyone that wants to review, I will help guide you through that. Thank you so much, and we'll see you guys next month.
Thanks, guys.
Thanks, everyone.
Thank you.
Take care, everybody.
Thanks. Good night.